We are live.
So I welcome you all to this special interesting webinar organized by Jharkhand Ophthalmological Society and Ranchi Ophthalmic Forum on surgical complications counseling, whether it is done by us or by any of us, our colleagues. So I'm going to introduce the subject of this very important webinar, how to put it across if we are have some complication, or if some patient has come to us and complication has been done by our colleague. This is one thing that has not been taught during residency training, and this interpersonal communication and conveying bad news is a communication skill that we all need to develop. There are so many strategies how to address a patient, sandwich technique of Rover sir, the PAT technique. So we are going to discuss all this in this webinar. The another topic is how to counsel unhappy premium IOL patients or their relatives. So we all know that cataract surgery has become more of a customized refractive surgery with a lot of patient expectation in this era. As per Concerto study, 94% of the patients who have been implanted with the premium IOL in one eye opt for the same premium IOL in the other eye. As per the Harmony study, 98% of the patients who have been implanted with premium IOL in one eye, they opt for the premium IOL in the other eye. As per US FDA trial, 97% patients who have been implanted premium IOL in one eye, they go for the premium IOL. But if you compare this with monofocal IOL, only 88% of the monofocal IOL patients, they opt for the same monofocal IOL in the other eye. Still, we cannot overlook the fact that there are fewer ones who are unhappy and how to address them. So we have very eminent speakers and moderators today. Padam Shri Dr. Ashok Grover sir is here, and Dr. Himanshu Mehta sir is here. So now I welcome our president, Dr. Raj Mohan sir, secretary, Dr. S.K. Mitra, treasurer, Dr. Vibhuti Bhushan, and Ranchi Ophthalmic Forum president, Dr. S.R. Singh. So now I invite our president, Dr. Raj Mohan sir, for his address. So over to you, Dr. Raj Mohan sir.
Thank you, Bharti. Good evening. Welcome to the webinar of JOS.
Good evening, sir.
I welcome Professor Grover and Dr. Himanshu Mehta to this webinar. I think this evening we are going to be enlightened with their experiences they have got in the clinical fields. Welcome all. Thank you.
Thank you, sir. So now I invite our honorary secretary, Dr. S.K. Mitra, for the introduction of our esteemed speakers. So over to the Dr. Mitra. Please share the screen.
Good evening, everyone. I just introduced, there is some problem with I can't share the screen. I will just introduce Dr. Himanshu Mehta. He is an ophthalmic surgeon in the chairman of Vision Eye Center, Juhu, Mumbai. Dr. Mehta is an senior consultant at Lilavati Hospital and Nanavati Hospital. He is at present president of Bombay Ophthalmic Association. He did his undergraduate and postgraduate studies from Seth GS Medical College and KEM Hospital, Mumbai. Yeah, thank you. Thank you. He did his super specialization in vitreoretina with Dr. Charles Gracia at the Hammond Hospital, Houston, USA. He is a speaker in various forums, nationally and internationally. He has been invited as a guest speaker and teacher at various ophthalmic associations. He was the eye surgeon at HH the Dalai Lama and was felicitated by him in 2014. A great achievement indeed. He was the first president of the Indian Intraocular and Refractive Society of India. He has to his credit the two law which he has patented internationally, the law of default, and the Waterman principle. He has his own YouTube channel, Mirror Wisdom Reflected. and he has a great passion for music and pursuing vocal and instrumental from renowned teachers. So welcome, Dr. Himanshu Mehta. The stage is yours, sir.
Thank you. Thank you very much, sir, for those kind words, Dr. Mitra. And thank you, Association, and especially Dr. Kashyap for inviting me this evening for this very controversial but a very important topic in life. I think we can learn how to do the anterior capsulotomy, posterior capsulotomy, vitrectomy. We can do all those things because 1, 2, 3, 4, that has to be done. But what you can't do is what we have learned for the past 30, 40, 50 years of life in human social behavior. Interpersonal relationship, patients' expectations, understanding what we can do, what we can give, what can be done for them. Now, these are all very, very important things which nobody talks about. And as she said, it is not taught in residency, nor can it be ever be taught anytime, anywhere. Only thing that can be done is we can see that we do the right thing in life to our patients at any given point of time. Tell me how many of you who are present on the screen didn't have a patient who's scribbing? Well, I'm sure nobody is here who can say that we don't have a patient who's scribbing. We have all got our share of problems. And whatever we do, even if it is a free patient in a free institute at zero cost, yet these patients can really mess up your life. There are people who are born cribbers, as I said. There are personality problems. And these are people, there somebody's might, yes. There are people whom you can't do much about. We have to understand and accept things in life. And the worst is if they have paid more for whatever surgery. Now, mind you, they are not paying you anything more. They are paying for themselves. And yet, when they have done that, they will still expect everything from you. And one of the reasons that I have realized, and I keep telling everybody across the country, because we as ophthalmologists have undermined ourselves. We have lost our value. We have overpromised patients. कुछ नहीं होगा आपको. No injection, no stitch, no putty. आप शाम को ऑफिस जा सकते हैं. What is the need to undermine your surgery? An ophthalmologist uses his left hand, right hand, left leg, right leg, and so that he can't do more, there is a voice intonation behind when you change a parameter. This takes at least 10 to 15 years of rigorous practice and dedication. And yet, we don't really have great respect for our own self. And believe me, as I say this, cataract surgery today is more complicated than a bypass surgery. I don't know how many of you have seen bypass surgery. But out of 4 vessel bypass, even if 2 vessels are not bypassed, patient will never complain. Because the pain in the ICU for one tube, another tube, CVP, central line is far too much for them to complain. And for you, evening, if they can't see their WhatsApp, you're not a great doctor. Well, especially premium patients. So to me, there is nothing premium about premium. Air conditioning was premium once upon a time. All your steering wheel for the car, your television, all that, your cell phone was premium. But nothing is premium. Everything that was premium is normal. Well, my slides are stuck. Let me just... There is a problem there, but let me explain that there is nothing like a premium patient here. And we will, I'm sorry about this, but this is exactly how things behave. It's not never under our control. And whatever you do, things may not work out well. But you try your best, you put the best surgery, you do a great capsulotomy, you do whatever that you feel is the right thing to be done for the patient. And despite all that, the patient may not be happy for you. And this is where the problem starts, because we have overpromised. And the answer to that is always under-promise and over-deliver. Never ever over-promise. This is yes. Can you hear me?
With a lot of echoes.
Yeah, I'll yes. Now, sorry about that. I was trying to get out from my laptop and talk on here. So the question about the whole story is with respect to premium surgeries, and the whole game of expectation is to see how we can under-promise the patient and over-deliver. Every time a patient is told that kabhi bhi chashma ka number nahi aayega, you are really doing a misfavor to yourself. You have created trouble by creating a Lakshman Rekha for yourself. I'm trying to get through with my computer meanwhile. Dr. Bharti, can we have a couple of questions coming on?
Okay. So
I'll just get my
yes,
laptop
yes.
working.
So
you can ask me questions because
I think Dr. Himanshu sets his laptop in between. So I request Dr. Bharti to introduce
Sure.
the panelist, our panelist, before you go to the further.
okay. So please first introduce Dr. Grover sir. I am sharing the screen from here. First, please introduce Grover sir. Grover sir. ऊपर है। Yes, please. मेरा unmute करो.
You are muted, Dr. Mitra.
Dr. Mitra, you are muted.
Okay, sorry. Dr. Grover doesn't need any introduction actually. He has been awarded the Padma Shri by the President of India. So President Padma Shri Dr. A.K. Grover, the Chairman of the Vision Eye Centers and Chairman Department of Ophthalmology, Sir Gangaram Hospital, is the President of Oculoplastic Society of South Asia, President of Ocular Trauma Society of India, Counselor at Large Asia Pacific Academy of Ophthalmology, APAO, Board Member, Afro-Asian Council of Ophthalmology, First President, Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery, First President, All India Ophthalmological Society, and is the First President of Oculoplastic Association of India. So, Dr. Grover sir, welcome you to this webinar.
Dr. Grover, you are muted. Dr. Grover, sir, you are muted.
Thank you for your kind words. My privilege to be a part of this meeting.
Okay. So now
Thanks for the invitation.
I want to introduce our own JAWS faculty. JAWS faculty. So more than 30 JAWS faculties are here. So just a brief introduction, one-liner, so that there will be better communication. So our JAWS faculty, Dr. B.N. Gupta is here. He is President ISOC. Dr. BP Kashyap is here. He is past president JOS and high volume femtocataract surgeon. Dr. Shalendra Singh is here. He is past president of JOS. Dr. Rajiv Kumar, he is the past president of JOS. Dr. Anup Gupta, sir, welcome. He is the vice president of Ranchi Ophthalmic Forum. Dr. Suja Samanta is here. He is the high volume cataract surgeon and the past secretary of JOS. Dr. SP Chakanwal, sir, welcome. He is the head of the Jamshedpur Eye Hospital, Super Speciality Hospital, Jamshedpur. Dr. Rajan Verma has joined. He is heading Eye Department of Tata Motors, Jamshedpur. Dr. Utpala Chakravarti is heading the Eye Department of CCL, Gandhinagar, Ranchi. Dr. Deepak Lakda is heading, Eye Department of Rio Rims, Ranchi. So the Dr. Rashi Shyam is the prolific glaucoma surgeon from Ranchi. Dr. Vivek Kedia is cataract and refractive surgeon from Jamshedpur. Dr. Bharti Sharma is heading cornea services at TMS Jamshedpur. Dr. Pritish Panoy is here. He's high volume cataract surgeon from government sector Ramgarh. Dr. Ravi Daulat is here. He's cornea surgeon from Jamshedpur. Dr. Nitin Dhira has joined. He is heading cataract and glaucoma services from Jamshedpur Eye Hospital. Dr. Mala Dwivedi is doing squint and pediatric ophthalmology in Jamshedpur. Dr. Abid Akhtar is a high volume cataract surgeon in Ranchi. Dr. Tirthajit Matra is here. He is past treasurer of JOS. Dr. Anand Shurut is here. He is the director of Anand Eye Care Center, Jamshedpur. Dr. Pradipta Kundu is the director of Madhureka Eye Care. Dr. Amit Jaswal is a high volume cataract surgeon. Dr. Ajay Gupta is the director of Rashmi Eye Care. Dr. Lukesh Jalan is the cataract surgeon from Dhanbad. Dr. Smita Anand is the youthful ophthalmologist from Gandhinagar Hospital, CCL. Dr. Lot of youthful JOS has joined. Dr. Jayanti Kashyap is an ophthalmologist working in Railway Hospital, Dhanbad. Dr. Anjali Singh is heading oculoplasty department in Jamshedpur Eye Hospital. So Grover sir, there is a request for you that you have to discuss the unhappy plasty patients also. Because she was saying all these surgeons are very high volume cataract surgeon. What will I do? I said, oh no, Grover sir is the most eminent oculoplasty surgeon. So you will get your
Okay.
you will get the tips from him. The Deepika Khedia is a pediatric ophthalmologist from Iris Hospital, Ranchi. Dr. Jahid Siddiqui is the director, Muskan Eye Hospital, Bokaro. Dr. Rahul is heading Vitreoretina services in RIO Rims, Ranchi. Dr. Nidhi Gatkar Kashyap is heading cornea services in Kashyap Memorial Eye Hospital, and she does a lot of DSEC and DMEC surgeries and gets a lot of referral for cornea decompensation cases. Dr. Pooja is here. She's a AIMS trained, RP Center trained cornea specialist. She is working in Kashyap Memorial Eye Hospital. So they all deal with a lot of unhappy patients, refer to them. So now I have introduced all the faculties who are here as a discussant from Jharkhand Ophthalmological Society. Now I am going to open this topic.
Dr. Bharti, can I just finish my presentation? I think
yes, sir. Yes, sir. Yes, sir.
I'll quickly run through that. Sorry.
Yes,
sorry
sir.
about the break earlier on. So let me explain. The premium cataract surgery or any surgery is a game of expectation. The more you give them today, nahi aapka chashma hat jayega. Koi baat nahi, there'll be no pain. The surgery will get over in 5 minutes. All these things which we say, we have put our foot into trouble. So what the patient demands and what they expect and what we can deliver, there is a big gap between that. So between reality and expectations, it's not like a Yashraj movie and they lived happily ever after. So the whole game that you've given to the patient today is a high game of expectation. And that's where my problem starts. The dangers lies in the fact that there is high expectation. So what is better for you? You know, when President Bush was at the top of his career before 9/11, he had 98% rating. Tell me, friend, what was the answer from after that? There was only one way out. He could not have gone to 110. There was only going down. So if you have a glass which is full up to the brim, there is little. So what you need to give is not empty glass to the patient, but half filled glass. So half empty and half full. Give them the full side, but the other half you can fill it up later. Because if you don't, and you do a good surgery, you are happy that you're doing a great surgery. Everything is going beautiful. You are enjoying the whole process. But you can be hit very badly. If you have given unnecessarily high expectations, you can be hit very badly. So the bottom line is happiness to any surgery is not just surgery itself. The surgery is just 40% of the whole deal. The major part starts from day one when the patient comes for consulting. And counseling to me is the most important thing for you to have less trouble towards the end. The less time spent in counseling before, that means less chair time before surgery, is directly proportional to more chair time post-surgery. So counseling is something which I would want to talk about. Always under-promise, over-deliver. Never make them underestimate the procedure. 5 minutes में हो जाएगा, दर्द नहीं होएगा, कुछ नहीं, अभी तो सर्जरी एकदम सीधा हो गया है. Ask any ophthalmic surgeon using phaco how much stress they undergo when the vitreous starts coming or the posterior capsule starts bulging. You have a brown cataract, one-eyed patient, bad corneal endothelium, a shallow AC, pseudo exfoliation. So it's like, as I put it, a Virat Kohli or a Sachin Tendulkar out of 100 test match is allowed to fail 30-40 times. Whereas all of us, despite doing 100,000 surgery, you are not allowed to fail a single time. The pitch may be different, the court may be different, the country may be different. You may be playing a fast arm, lower spin, England, Lords, Bombay, wherever, but you have to give results. So be careful what you say. That would be great if you could meet the expectation. So again, as I say, under promise and over deliver. Again, I want you to get this very, very clear in mind, and that's why I say. And of course, when a patient asks for too much, कि नहीं मेरे बाजू वालों पे चश्मा नहीं है, मेरे को चश्मा पहनना ही नहीं है. Learn to say no. I tell them very clearly, I am not God. Even in my LASIK patients, I tell them, number kabhi bhi zero nahi hone wala hai. So giving into the patient expectation pre-op, the game is won or lost before the surgery starts. Now, if somebody is refusing to put in a premium lens, don't worry. Tell them it's perfectly fine. It's not for you. It is for those people who understand. Leave it. Don't push too much. They will automatically go for that. Now, how would you select patient? It's very important. Of course, you are going to be beware of all those patients which you have to be careful. Those who are happy wearing glasses, those who want guarantees. No guarantee given. That is a fact of life. Anti-anxiety and psychotic patient. They can change their statement anytime. And don't worry about the pricing. Don't think that it is your price which is making the patient run away. Price is what you pay. Value is what you get in life. So people pay for values, and service is not a product.
Sir, your screen is flickering actually.
My screen is flickering, is it? Okay, I thought it was straight. Back, can you hear me? But back to the...
Yeah, we can hear you, but it is just coming and going.
Sir, we can hear you, but your screen is flickering and it is not coming, disappearing, appearing, disappearing.
Oh my God, I'm so sorry. I see it as a straight ahead scenario. Maybe my internet is not very good. But anyway, I quickly go through it. So stay up to date.
Yes, it's more of a discussion.
Error in planning, error in measurement. Be very sure that there is nothing wrong with what all your preoperative understanding about life. Be very careful. Counsel the patient and listen to them. In post-op counseling, listen to their problems. Honesty, clarity of answers, no ambiguity. Look into their eyes and answer. This is something very, very important post-operatively when the patient comes cribbing. Humane attitude, the most important thing that a doctor requires is humane attitude, that is empathy, sympathy. Don't hide, don't neglect, don't run away from problems. So tips are simple: smile, infuse enthusiasm, encourage more questions, don't get irritated. So add humor, buy time, increase their self-confidence, have an upper hand on the psychology part, and involve the family. I guess I'll take over right now. I'll stop because enough. I don't want to bore the crowd. I'll stop share. We can start with the question answer session. Sorry.
I think we should, sir, also I will add a point that we should hear out the patient and we should show some concern, because either we should not be very defensive or dismissive. If we give him chair time, if we show our concern that we are listening, or even if we have to fake that, yes, we are listening, you have a genuine problem, tell us what is your problem, because half of the time, sir, patient listening also has a psychological impact on the patient, and sometimes the patient, instead of the problem with us, the patient has a problem with the... Hello,
Yeah,
am I audible, sir? You are
yeah,
muted.
audible. Yes.
So sometimes the patient has a problem with counselor or the front desk or staff, and he's irritated. So when we give them show them a concern, and the patient hearing some problem is solved.
Totally agree. Listen to them, look into their eyes, don't run away. Time, spend time. Patient needs your time. That's all. And the more you give them, like, a lot of senior people have told me also very clearly, even if there is a complication in a patient, but you have spent time with them and they know that you're doing your best for them, they will thank you for that, despite the results not being very good.
Yes, sir.
Sir,
And I have also seen that some of the patients who had complication and we treated them well, we gave them a nice chair time, they bring more patients. So, sir, you have to stay because we have two more topics and you two are the major discussant, Grover, sir, and you. So our next topic is the complication which has been created by us. So the tips and tricks, which is the way out, how we should deal with the patients when we have created the complication. The complication has been created by us. So Grover, sir, please share your tips.
Sir, you are muted, sir.
First of all, the complication has not been created by us, but it has happened. So first thing is not to be defensive. That is the most important thing. We know it is an integral part of surgery for any surgeon, and the only surgeon who does not get complications is the one who does not operate. I mean, this is the cliche saying which we all hear so often, and it is so true. So a surgical mishap is something that will occur to every surgeon, however infrequently or relatively more frequently, depending on what type of difficulty you're talking about. So the first thing, as Dr. Himanshu pointed out, was not to be defensive, look the patient in the eye, communicate well. So when a complication occurs, there are certain things that must happen intraoperatively. There should be no panic conveyed in your voice or any hurry communicated or any tension communicated during your communication. When a complication occurs, be very comfortable, be very cool, and talk to your assistant in a calm, cool manner. If you want the vitrectomy to be switched on, tell it in a matter-of-fact way. Don't get irritated if it takes a minute or two. Be patient, and be patient with your junior colleague if you've told him to get another lens of another power. All communicated in a matter-of-fact way, but of course, they must all know that how to communicate. Your surgeon, your junior should not come back and say that, okay, this lens is not available. He should maybe talk to you on the side, communicate very silently, very peacefully, and the atmosphere of the OT should be very peaceful throughout the surgery. And at the end, you must tell the patient that everything has ended well. That's the first thing. So, you've heard of the sandwich technique. You start with something very good, communicate the bad news in the middle, and end with something very nice. So you can say that, well, you were excellent. You cooperated very beautifully. Tell the patient the surgery went much longer because of the difficulties, but you were so good and you cooperated so well. You can start with that. And then, of course, when you talk to the relatives, tell them that everything has gone off very well. Now, there was a difficulty because this patient had such and such problem. He had a weak capsule, or he had we had a difficulty because of a certain thing. And we could manage to do this. We had to clear the jelly or the vitreous, and it has ended very well. We've been able to place the lens. Only thing is, it may take a little longer for recovery. We may need to take precautions for a little long, but we expect the result to be good. And we will, of course, require you to be patient, but we will see a good result, hopefully, and you should have no cause for concern. So if you tell everything about the procedure, everything about that has gone wrong, but in a very matter-of-fact way, with no panic, no sense of guilt. That is very important. I think that serves the best purpose and gives you the best contented patient. Many a times patients are equally happy or even happier that you worked so hard in a situation like this. You can say that the pupil was very small, we did everything that was required, or the cataract was very hard, and the result will be still as good as we expected it to be. I think those are the things that the patients want to hear.
Himanshu, share
Yes.
your tips and tricks.
Yeah, I couldn't agree more with Dr. Grover. You could never say anything second otherwise. But one thing that I would want for all the OT staff to be very clear about, there should be pin drop silence.
Yes.
In any other anesthesia, there is general anesthesia. You can do what you want, you can say what you want. Most often than not, the anesthetist talks on the phone. The assistants talk on the phone. There is panic. Hey, kya kar diya? Kya kar diya? Hoy, kya ho gaya? Kaisa karta hai? Aisa kya karta hai? Now, this is what imagine you are a patient, you are lying down with everything closed except a light in front of you. Your ears are very sharp now. You will pick up the slightest sound of what people are talking around you. And believe you me, I have seen patients where somebody has talked about some other patient, some party they were talking about, and something else, and the patient took it on them. Surgery was fine, but the patient started cribbing. They were not concentrating on my surgery. They were more interested on the Saturday night party. So be very careful who's talking, what is talking. There has to be great amount of theater manners. We are doing it under topical. We are not sedating them. We are not doing anything. Be very careful of every word that is said. Any negative word will be magnified because they are only listening to you carefully. And if they hear panic, as Dr. Grover said, they will realize, they will start panicking, their blood pressure will start shooting up, and you have V-loss, they'll be bleeding, they'll be oozing starting very soon. So be very careful. And as he said, you have to tell them that there is a problem, it will take a little longer. And if you have promised, unfortunately, कि 5 minutes में हो जाएगा, and you have a problem, or 15 minutes तक चलता है, now you have to justify. So you have to be very clear, tell them that no, it will take time, don't worry, but we are trying to take care of everything properly. So I think this is very important, manners in the theater. You have to be very careful. And then talking to the relatives is even more important. Very, very, very important. And especially there is one person you will realize who's the main communicator in the family. Before surgery also, there is a major talk which I like to give, that there is a major person who's the guy who takes the call. Everybody looks into their eyes, that person's eyes. So you have to take that person with you. You have to find out who's the main leader in the whole group, because before surgery, maybe nobody was coming with that patient or one person came. But after surgery, suddenly, if there is a complication, 50 relatives will come and swoop on you. This is the standard scenario. So you have to be careful of what you are saying, be confident. And as he said rightly, stick on your ground, be sincere, be serious. Don't laugh it out. Don't neglect them. Don't give it to your assistants. And tell them there was a problem. We have taken care of it. And if need be, in time, take a second opinion. Tell them for your benefit, please, I'll send you to a colleague of mine. Share responsibility.
Yeah, I think two things are very important. I think Dr. Himanshu has hit the nail on the head. The confidence, eye contact, and absolutely no sense of guilt. I think that is very critical. And how good a rapport you've developed with the patient beforehand, intraoperatively, how well you were communicating, and postoperatively. So postoperative chair time may be more for that patient. You may need to prioritize that patient when he visits. Maybe he needs to visit more often. Give him a little priority. Give him that little extra rapport. And always avoid that sense of guilt. you've not done anything wrong. It is bound to happen in a certain percentage of cases and with certain circumstances. And that's the principle, again, which you need to apply to yourself and to others' complications. So this is why when we talk of the second question, the same things come in. So, and again, true empathy, as again Dr. Himanshu was saying, if you are genuinely concerned about him, and that reflects in your manner and in your way in which you deal with the patient will come back even more grateful with possibly as good a result, or even if the result is compromised a bit, he would be with you if you kept that rapport and communication on.
I have, sir, if you allow me, one thing to add. And that is, when per operative, if you have seen that there was some complication. So, it reminds you every time, when you're in OPD, whatever you're doing, you think of that patient, pata nahi us patient mein kya hua. So what I have done is, the very next day, I asked my ward sister to call him up on telephone. By us patient ko dekho, find out his telephone number and just ask him how is he. It makes a lot of difference, because on the day of surgery, because if you have messed up a little bit, so if the vision is a little blurred, next day it's a little better. So the patient will always say, yeah, kal to kuch nahi dekha, I'm feeling a little better. And the patient feels better. And then he has some regard for you that doctor is taking care of you. This is my point I wanted to share with you.
And I want to add one more thing. Like what I feel that pre-operative communication is very important, as well as writing in the prescription and the maintaining in the electronic medical record. If the patient has posterior polar cataract, risk of drop, risk of PCR, if there is any uveitic cataract or any corneal issue, there should be a documentation and the pre-operative information, and it should be documented. Documentation is very important, because वो तो बाद में बोलेगा कि आपने तो मुझे पहले बताया नहीं कि मेरे कॉर्निया में एंडोथेलियल काउंट कम है, या मेरा EBMD है, या मेरा गटाटा है, आपने तो पहले नहीं बताया. तो इसलिए मुझे लगता है कि प्री ऑपरेटिव कम्युनिकेशन, clear communication is very important, as well as documentation.
I have one question. If a situation, right, if we don't tell the patient about the common complications which are bound to occur, like PCO, so the patient may need laser later on. So how much should we tell the patient about the post-op complications, and how much should we not? Because if you tell too much of complications, the patient gets skeptical about whether to go for surgery or not with this surgeon. So how much should we tell about the possible post-operative complications, and what points should not be discussed in detail? That's why I want to.
There are certain complications or difficulties which are quite common. They need to be spoken about. I mean, if we are going to do a multifocal, you must warn about the possibility of night glare or sensitive persons being aware of the night vision phenomena that occur, that can possibly occur. And you must tell them that if you are a sensitive person, or if you're going to do a lot of night driving, and you are a person who notices minor things, then possibly think of another alternative. I might offer him one of the extended depth of focus lenses that are available today, or a monofocal, depending on his inclination. So those kind of things he must be aware of. But a thing like PCO, I would not tell every patient, or I would not say that you can, in 5% of the cases, develop a posterior capsular opacification. It would be in the record of things that we have, but that cannot possibly be communicated to everybody, or a 1% possibility of uveitis, or a 0.5% possibility of a pressure rise, or something. Those things cannot be technically discussed with all patients. That would need to be done in a setting where we do 4 surgeries in a day, or like in the US or in UK or something like that. We can't do that. It's not practical, and it's not called for. It should be written in the thing. And when and if that occur, you can tell them that this is an infrequent thing that happens. But of course, if there is something which can happen, which can have a catastrophic consequence, like let's say, if I'm doing an orbital surgery, I must talk to him about the 0.5% possibility of vision loss. Those things cannot just be written. Those complications which can have a profound impact must be spoken about, and others which are common need to be spoken about, even if they are relatively minor. But for the others, I would probably not speak to the patient. I would tell them that there are other things. I might have a brochure with them, which is important. They must have a brochure given to them, or they must have maybe made to watch a film or something which shows up all those things. But what I do is I give them a written set of instructions and a brochure which lists out all the things. But further than that, verbally, I would not communicate.
So do you mention PCO in the brochure?
Yes, it's there.
Sir, I have one question. Hello. Yeah. Am I audible?
Yes, yes.
You are.
Yeah. So my question is, an active male, say pre-retirement, around 55-year-old, and he is very much enthusiastic for trifocal. So how additionally we should counsel the active male patient? He is night driving, so and then he's very much interested. He's saying that I want trifocal or multifocal lenses. So what extra do we need to give in counseling is one question. Second is, in your trifocal, what is your pickup, sir? Which lens do you prefer?
Okay.
Dr. Himanshu first.
This is a very, very important question. I am a great proponent of multifocal, so which is why I'm taking this question head on. This is exactly the whole thing. First, sir, you need to be convinced in your heart that you are convinced that a trifocal is good for the patient, or this trifocal is good, or that trifocal. The lens will work exactly according to your conviction. And how much have you convinced the patient? So if you are convinced about whichever lens that you are convinced, that lens will work for you for that particular patient. And you have to titrate, because you will have to have your A scan, your A constant, which has to be done. So I tell them very clearly, and I do for some very, very super VIPs also, multifocal, trifocal. I am very happy. I think one of my topic which I like to talk about is multifocality is a birthright. Cataract surgery is a game changer. Tell me how many of you agree with me that despite telling a patient that the patient is ready, that paisa nahi kharcha karne ka hai, monofocal dalne ka hai, how many of them come and crib to you that my neighbor is not using glasses, how come lens dalne ke baad mujhe chashma hai? Tell me how many of you, please nod your head, raise your finger. Correct. All of us, all patients come and crib. Yes, I'll put two hands actually. They all come and compare. Ki mera baju wala ya my husband is not using glasses. Mujhe to apne lens dala na. So the onus comes on you that this will be there. Despite putting a multifocal, with the best of the patients, I tell them, you will get a number. I am not God. God also goofed up. That's why in a population of 130 crores, 80 crores have glasses. So I'm not the only one who is goofed up. So be very clear about that. So
how do you deal with the night driving problem and all? Because most of the male patient.
Sir, I ask me frankly, most of them, I've got interviews of patients who have done this lens, and they have told me that they have no problems with night driving. So how many of you drive at? Sir, do you drive at night? You are wearing glasses. Let me ask you, all those who are wearing glasses. Now, okay, tell me all those who are wearing glasses, driving at night with the headlight coming on, do you have problems? Yes or no?
Yes.
Yes.
Thank you, sir. Thank you for sharing a correct answer. Because the new Beamer headlights, the headlights and all today, and all are Shivajis. They want to give a double dipper. Main pehla jayega, aap baad mein jana. I tell you, in a crowd of any crowd I pick up, ask the relatives. When the patient is sitting with you, ask 10 relatives. How many of you have a problem driving at night? And I'll tell you, all of them will tell you, yes, they have a problem driving at night. So this is in our mind. What is one of the things which has been taught to us? That you remove a cataract when there is glare problem. Glare. Glare is the essential part of cataract surgery. Now, to me, this is a big problem in our mind. If out of 1 lakh patient, 3 patients have trouble, should I make other 99,900 suffer for that? I don't think I'm justified with that. Second, I'll tell you, of course, you will not put this lens in a night driver. But let me ask you, out of 1,000 hours of driving, how many hours do you drive at night, sir? Maybe 50 hours, which means 950 hours you want throughout the day what you are seeing. Throughout the day, total driving time maybe 1 hour or so, half an hour. Every day, 23.5 hours, you want to suffer because you don't want to suffer for half an hour. I think it's the most ridiculous statement, and it is the most exaggerated statement of life that people put up. Yes,
Absolutely
few people
right.
have trouble. Okay, second, I would like to ask quite a few of you. Even after putting a monofocal, how many of your patients complain of glare at night? Please ask your patients. So this is what it is. Yeah.
Okay, sir, we got it. When the normal person can get a glare,
So my point was that,
so they are focusing on glare, and most of the time,
Madam,
the daytime facility they are forgetting.
madam,
Which is your preferred trifocal?
you see a glare in a room when you look at the light. How many of you keep looking at the light throughout the day? Tell me. Nobody. So you have to be convinced, sir. My point is only one. You have to be convinced. And out of the modern the trifocal that we have, you have to decide which one works for you. I'll give you my secret. I am, as of today, convinced with a Synergy. And it's a very forgiving lens. I'm getting good. I'm quite happy with it. That doesn't mean PanOptics is wrong. That doesn't mean the other lenses are wrong. The Indian lenses are also good. You have to try it out. First, get convinced in your heart, body, and soul that what you are doing is effectively right for the patient, not for your ego, not for the company. Anyway, we don't make money on lenses. I wish I had a company who was selling lenses. We are not making money on lenses. So this is my answer with respect to trifocal, the glare aspect of life, and which is the present one.
And sir, one more
Sir.
thing.
You're muted yourself, Dr. Bharti. You muted.
Sir,
Dr.
what is your experience for VVT? They say that this is 40 centimeter, but then, sir, they need glasses.
100% they need glasses with VVT.
Yes.
100%. I promise them that you will need glasses, even though I give minus 0.5 in one eye. I'm a great believer. Even in all monofocal patients, I do monovision from last 20 years. So in multifocals earlier on, Symphony and all also, I used to do micro monovision. So here, 100% I keep minus 0.25 in one eye and minus 0.75 in the other eye. Because it's fine if they can't see the score at night. But if they can't see their WhatsApp, they are very unhappy with you.
Yes, sir. You
So
are right.
what I would stress is,
Multifocal also you target little myopic in one eye, micro.
Yes, sir. But that's why I said Synergy to me, even a 0, still they read well. Sir, the problem of reading disappears with only one thing in life. This light of the phone. Just tell them to switch on the light on the reading area. All your problems will disappear. The problem is
Contrast, yes, sir. Contrast sensitivity will reduce.
Yes, sir. Yes,
That is the
sir.
main.
one is contrast sensitivity and 2 is pupil dilatation. All the errors of refraction are magnified when the pupil is dilated. So if you, with a little more light, it will constrict, it will reduce the contrast, and you can read the menu in the restaurant very easily.
Sir, we
so
can
there
say.
are two things, Bharti, that I would stress.
Yes, sir. Yes,
I'm
sir.
a fairly avid VVT user. And the reason is that it converts a much larger extra group who I would not have advised a trifocal. Let's say somebody who has a relatively larger cup, and I say that I will investigate you later, whether there is a glaucoma or not after cataract surgery, or there is some pigmentation on the central area, or there is a child about 8 years old with a monoocular cataract. All those are cases I would not use a trifocal. Those are people I would go ahead and put a VVT with much more confidence, with very clear understanding that it is a lens which would give you intermediate vision onwards with a clear option for monovision. Now that monovision, micro monovision can be extended from 0.5 to 0.75. And I tell them that we would sacrifice a line for distance for you. And if you so desire for the second eye, I don't talk about the dominant or non-dominant eye, and I don't think that has made any difference to me. I would do the first eye emmetropic and I would do a micro monovision in the other eye. I don't know whether Dr. Himanshu agrees with that or not.
I just wanted to ask, what is your counseling? I mean, during counseling, what is your first choice? Actually, I am one of the fan of trifocal. So I normally insist or counsel the patient for the trifocal first. If the patient or his condition doesn't permit, then we go for the monofocal, not for the multifocal. I don't use multifocal nowadays. I'm using maximum the trifocals, and all trifocals I'm using like Tri-Diff, I'm using Zeiss 80 Tri, and all the lenses are doing good. It's not that any particular company's lenses are doing good. All the lenses are good according to the situation of the patient. So what
I
is your
agree
take
that
on suggestion of it?
trifocals have made a huge difference. There was a time when it was multifocals and we had night vision difficulties, relatively more common, and an occasional unhappy patient was the reason why we were not advising the trifocals, but the multifocals. But since the trifocals came in, the night vision difficulties have certainly decreased. There's no question about that. And I use PanOptics a lot and Tri-Diff as well. And I'm quite happy. I find virtually no patient complaining of night vision difficulties. And I totally agree with Dr. Himanshu that it is your conviction in a particular lens, which is so easy to communicate in your talk to the patient and discussion with the patient and in the results. So, for example, I'll take an oculoplastic example because Bharti wanted me to take. Nobody was doing a bilateral surgery for a severe unilateral ptosis. And I had always been doing that. So the question always asked was, how do you counsel your patients? I said, I don't need to. I just tell them that, oh, this is the best procedure for a severe ptosis because it gives the best symmetry. There's no other procedure which would give you a symmetry. And I virtually found nobody who said no. In fact, when I stopped doing too many fascia latas binocularly because of the ease of silastic sling, a lot of patients came and said, but that patient said you would do a binocular with a fascia lata, so why don't you do that? And then I had to do that. So it's a question of your conviction with the procedure that you are doing the best for the patient, which communicates to the patient. And trifocals have certainly made a huge difference to the quality of vision that you're giving to the patient. And the percentage of our patients which were trifocals were less than 5% are now much. Trifocals and EDOFs combined are much closer to 25 to 30% for me now.
Sir, I have a question to you. When we do VVT, we make one eye emmetropic and other eye 0.75
if the patient so chooses.
But you said that you do 0.5 in one eye, or Himanshu sir said, and 0.75 in the other eye.
0.25 and 0.7 he said.
5 in the other one eye and 0.75 in the other eye.
0.25 minus 0.25 and minus 0.60, 0.75, whichever comes near that area.
So why you do conduct myopic in both the eyes?
That is what I have found, that it becomes a lot more easier for them. Again, I'm repeating, 99% of their time is in a room, either looking at a secretary or their job or office or their closed presentations or their television, or the stock market guy is looking at 3 screens, but most is the phone. The biggest thing is the phone. So if you have managed to do that, they are comfortable in 95% of their time. They will not crib for anything else.
Okay, sir. Sir, what do you do for synergy and panoptics? उसमें भी करते हैं क्या?
नहीं, synergy में जरूरत नहीं पड़ रही है, इसलिए मैंने कहा it is very patient, it is doctor forgiving. That is what it is. So Minivel is another. Those who don't want rings, I'm very happy with the Minivel lens. Minivel is a nice lens. They use in one eye different Minivel. It's just the aspheric part which is used now, way better than your eye hands. And the other eye is a Proxa, which gives them reading for near. A beautiful combination of 2 lenses, which even Hoya has come up now.
Yes, sir. They were talking in the conference. So one eye has a lesser near ad, and the other eye has a more near ad.
So distance, again, it's fine. The whole thing is circle of confusion or diffusion. They are expanding on that. Everybody is expanding on that.
Sir,
So
what is the name of this Hoya lens?
I forgot.
forget
Geometrics. Geometrics.
Geometrics.
Yes.
Geometrics.
Yes.
So they were talking. So have you used
in
Hoya
geometrics,
geometrics?
They're not changing they're just changing the percentage of light for distance and near. That's the difference from mini well. But then this also is giving a very good result. I've
Sir,
used it.
geometrics के बारे में बताइए. What is your experience? कैसा है वो?
अभी बहुत कम यूज किए, 3 यूज किए मैंने, 3
कैसा है वो तीनों का?
तो वो पेशेंट्स अच्छे हैं, they are happy.
I've used 2 patients. On 2 patients, both the patients are very happy, and I found that probably in the near future that will be my IOL of choice.
Great. Great, doctor. So that's why I said, again, we repeat at the cost of conviction. Whatever you are convinced is what your body will show and your results will come. Somehow, whether you like it or not, in the global phenomena of this world, your mind waves will be synced with that mind wave, and tell the patient to be convinced. This is what I'm using. You will still need glasses. I am not God, because the effective lens positioning, ELP, the spatial orientation of the patient, there are so many factors. So I mean, I give them a very simple example. COVID medication used for 100,000 people. It did not work the same for everyone. I don't manufacture lenses. I don't sell lenses. I'm doing the best possible calculation. How it works in your eye is your and my good luck. Though majority don't need glasses, but you may need glasses, period.
So
Sir, but ये तो बोलना होगा ना.
stress is the lenses are only available in 0.5 power.
Correct.
And there are so many media in the eye that you cannot get 100% result. I say I would get within 0.75 diopter in 95% of the cases with my best available biometric formulas and biometric machine. So there may be those beyond 0.75 also in 5% of the cases. So it is important to emphasize.
तो सर पेशेंट को क्या बताना है फाइनली कि आपका 2.75 तक जा सकता है और 5% पेशेंट को उसके ऊपर
नहीं, the other way around. I would put it like Dr. Saab ने बहुत अच्छा बताया ना, sandwich technique. You say it the right way. The whole thing is how you say the whole statement and how you put it across. I tell them that today you are wearing glasses 100% of your waking time. Dr. Mitra, if I have to tell you this, you are a patient, you need a lens surgery. Sir, do you wear glasses throughout the day, 24 hours? First thing in the morning, do you look for glasses? Yes, sir.
Yes, Dr. Mitra, tell them.
Yeah.
And the last thing you do is remove your glasses. Am I right, sir?
Yes.
Okay. If I tell you like a normal human being, okay, I will, whatever I do is one, getting rid of your cataract, which you will have to do. And I tell you that 90-95% of your waking time, you will land up not using glasses. Maybe for raising the stock market rates or Times of India, you may need glasses. Tell me, would you be happy? Yes or no?
Yeah, definitely.
That's it. That's the answer.
Okay, sir.
True.
So, sir, should we move to the third topic?
Yes.
Our question was, how do we deal with the unsatisfied patients? Because if the patient has paid a lot of money for the premium lenses, let's say one patient was given a pan optics, the pre-operative IOL calculation and the post-operative IOL calculation after the surprise, it was same. The operation was uneventful. The surgeon knows that, oh, I did my best. There was no complication. And the patient needs minus 2.5 diopter cycle for 6/6 for the distant vision. The patient is not happy. I'm surprised when I informed the company people, they said, let me check. We will give this query to the company, to the parent company. So how do you deal with such patients, Dr. Himanshu?
A very important question. This is where you are the crucifix. Everybody, the patient blames you, IRDA will blame you, everything, and the lens man and the company will never ever take responsibility.
Yes.
Because the lens is inside the eye. There is no way in which you will be able to find anything now. So it is your responsibility and onus. At the most, go and do a refractive surgery after 6 months. Simple, very simple. Or put in a second piggyback lens. Take responsibility. You have done all calculations. You have done on paper. There is no fooling around with that. And despite all that, this is how the eye has behaved. This is what I would like to help you to get rid of your glasses. You've done nothing wrong. You have to stand by your statement. I have done nothing wrong, and you have to be confident, period.
Sir, for minus power, you do laser vision correction, and for plus power, piggyback?
Yes. So if I need to, I would do that.
So if the patient
There is
has
an error, like Dr. Kashyap said, that if there is an error like this, where you've done the correct calculation, despite that the patient needs -2 and you are perplexed, there's a big discussion which can happen on this, actually. What he said, this rarely that you will get a case like this. And the company will never take the responsibility. Yes.
It is quite
and
rare.
sir, for LASIK or PRK?
Whatever you are happy with, madam. There is no problem, because anyway, LASIK karo, kuch bhi karo, a 60+ patient is not going to get ectasia.
May I ask one question?
Yes.
Yeah, my question is, what is the limit of astigmatism when you are going for toric multifocal and leaving the multifocal one thing is one. And the second is, how do you rely on the steep axis incision, and how much astigmatism do you feel that steep axis astigmatism will be okay for this patient? I will not take the toric multifocal and only multifocal will be okay. So what is the amount of astigmatism that you titrate based on this decision?
Dr.
And
Grover,
whether you want to go for toric
I think
multifocal
the first thing is that the tolerance for astigmatism is much less with multifocals than it is with monofocals. So
Yeah.
0.75 is a very good figure, kind of rough guide. But if you are basing it on anterior keratometry, there will be a little difference on whether it is against the rule or with the rule. With the rule, you would probably accept up to 1, maybe 1.25. But for against the rule, you would be 0.75 onward. You would be not accepting at all, But still, it is better to stick on the 0.75 to maximum 1 figure. And as any astigmatism more than 0.75 should be a taboo or should be corrected by one of the means. If you are using a femto, in that case, you would do a femtokeratotomy. So that's okay. Maybe you can go up to 1.25 with femtokeratotomies only. But for others, think of a toric, anything beyond 0.75. Because when the patient is thinking of a lens which is costing more, or premium lens as it is called, then he's willing to go for the extra correction. And if you have not offered that choice, he would blame you for whatever residual error that he's left with. So 0.75 is a useful figure for that. And of course, with a little difference in basing on anterior keratometry with the rule and against the rule.
And do you rely on 0.5 astigmatism and giving incision on steep axis? Preferring
earlier, we were giving a lot more emphasis on the steeper meridian incision when our incisions were 2.8 or more. With 2.2 incisions, there is hardly any difference. We calculate it as at 0.2, but with the centroid method, which is now accepted, it is probably 0.12 or 0.13 rather than an actual 0.2 also. So there is very little that we are changing by on the steeper meridian incision. And increasingly, we don't alter our incision based on the astigmatism as we used to do very often earlier. Since it became 2.2, since it became known that by centroid method, it's even the actual impact is even lesser. We no longer orient ourselves or change our positions, make ourselves more comfortable just to reduce that astigmatism by 0.12 or something.
Okay.
Dr. Mash?
Yeah. Thank you, sir. Brilliant what Dr. Grover said. I couldn't agree 100% with him. But sir, if you've seen all Dr. Nitin, even if you put the best of the lenses, whatever you do, there is always some residual astigmatism. All those who do LASIK also will agree with me that there is never a zero number. There is bound to be something else.
So Dr. Himanshu, what I always say is, you go around and do 100 refractions of any people on the street. Would you find anybody with 0.00? So nobody gets 0.00 even in the nature.
So
he has not been able to create one. So how do you expect us to create one?
Actually, I have been also doing in my practice. I give more importance to the counseling part. Don't make tall claims. always keep the patient in guarded way, and you tell them that you may need glasses. If patient doesn't need glasses, patient is very happy. Otherwise, patient doesn't mind. So I think proper counseling, whatever lens you are using, whichever technique you are using, I think proper counseling is very important.
Yes, totally. So I couldn't agree more with you.
So should we move to the third topic?
Yes.
Yes.
So
Okay.
let's just
So the
repeat his
third
golden
topic,
words, Dr. APN's golden words about under promising and over delivering. I think that is the key. The only other thing that I would stress is the personality type. Monofocal or multifocal, you could be in problem with that. So better to err on the side of monofocal in those personalities who are the over questioning type, who are the hypersensitive type, or who will take 15 minutes to ask you questions. Be sure to promise them the simplest and the least costly lens. And then if they insist on something different, then that is a different issue. Just beware of that personality type. It's more often a personality type which gives you problem rather than the lens or the performance of the lens itself.
Your statement, sir, Dr. Himanshu, on this?
On what? Sorry, on specifically?
Type 1 personality.
Patients, people talk of premium lenses. You talk of premium patients. So there.
Sir, every
Type
patient,
1 personality.
the type 1 personality, there are certain, let me put it the other way around. I would put it the other way and forget type 1, type 2. In fact, if you ask me, one of the things written in literature is with a housewife, you can use any lens. I disagree. With a CEO and the most busy person in the world, you can put any lens, he will never crib because he has too many things on his agenda. Whereas a housewife will go in a kitty party and keep discussing nonsense, and other people's problem becomes your problem. उसने बाजू वाले को सुन के अपने का तकलीफ देंगे आपको. So question is premium lens or premium is in our mind. You have to, whoever it is, you have to look into their eyes and tell them, this is what I can do. This is my limitation. I'm a human being. Don't expect me to be God. नहीं, आप तो भगवान ही हैं, doctor साहब. Nonsense. The day you feel, I tell them, the day I tell you I'm God, run away from me. Don't even see my face. Very clear. Tell them on their face that I cannot give 100%. मैं कुछ नहीं, मैं आपका problems ना तो मैंने problem दिया है. First, you have to reduce their demands. Did I give you a cataract? Did I give you glasses? I'm sorry, I'm very, very, very dangerous to talk at this point. But I tell them and look in their eyes and tell them. I said, one place you can go and complain. There is a hotline with God in the temple. You can pick up the phone and talk to him. I did not give you glasses. I did not give you trouble. I did not give you cataract. I did not give you astigmatism. I am your friend. I'm trying to sort these problems for you and help you. But I have my limitations of the equipment, technique, and the lens available. After this, if we can arrange and come to a good point, welcome, I'll do the surgery.
One more word in oculoplastic context. One thing that I tell them is that this is the best that I can offer, that this is the probability, 90-95%, that you will be within 1 millimeter with this particular measurement. But you'll have these shortcomings, like maybe in a ptosis case, a lag of thalamus and lid lag. And then there are those who still keep saying, why would this happen? Why does it happen? So then I tell them that for anything better than that, you have to, or better probability of results, but ठीक तो हो जाएगा 100% ना, तो वो, then I say, then you have to go and talk to the original manufacturer, जिसने ये defect दिया है, कि वो original replacement कर सकता है.
ये तो बहुत अच्छा.
I have one question. I'm allowed. Good evening, sir. So this question is for you, Grover sir. It was just my experience that one entropion correction after 1 year came to us with a recurrence, and like okay, it's like we know that retractors might keep on getting weakened up and it can reoccur, but like how to, is it like safe to already explain it to the patient at the first go only that after 1 or 2 years there is some chance to get a recurrence, or just to like wait for it to happen and then only talk about it?
No, I think those things can be spoken about, that even with all the aesthetic procedures we do, that The recurrences are improbable, unlikely, but can occasionally happen. This is what I would tell them. Because and this is an age-related change. We'll be correcting it to the best of our ability. But recurrences are known with the kind of procedure that I am doing. The recurrences are lowest. Let's say if we are doing I'm doing a Jones procedure and tightening at the same time, I would explain that this offers the least probability of recurrence. But it does and can occur.
And also, immediately after our orbital cases, there is redness and some of
Restriction
the
of motility.
ecchymosis, diplopia, and so, but like in the rarest case, definitely theoretically loss of vision is also associated. Again, not common, like only in the intracorneal quite posterior lesion. So is it again safe, or like should this needs to be informed beforehandedly? Like
100%.
it's very remote, but it
Even
can
in the
happen.
orbital fracture cases where the probability is even lower, maybe one in, I've had one in my possibly more than 1,000 cases that we've done. But I talk to each patient and tell them that there is a less than 1% probability of loss of vision, because if something like that happens, then he would not accept that it was written in the instruction. And orbitotomy cases, all of them positively. You have to tell them about the unlikeliest possibility if it is severe enough. So, and of course, the commoner things, that possibility of undercorrection, possibility of overcorrection, lag of ophthalmos, lid lag, things like that. 100% of the time you have to speak about, which are common, or those which are rare but can be devastated. Those we have to speak.
Thank you so much.
Any other question, Aditi?
So that way, even the for the surgery for glaucoma, the Dr. Shyam Rashi, what do you say about the recurrence of glaucoma? I mean, the flap becoming the bleb becoming flat, and again you get some increased pressure.
Failure trabeculectomy.
Nitin, you can answer. Rashi, I think, has not joined.
No, I'm here, ma'am.
Okay.
Yeah, actually,
do you do?
for glaucoma patients who've already been through filtration surgery, ma'am, I don't think, I mean, premium IOLs, I would not like to do, because their astigmatism is quite unpredictable. Even after many years, if the bleb becomes cystic or overhanging, then it causes astigmatism, and that can totally make the cataract surgeon's efforts moot. The other thing is that if there is a bleb, then always use a temporal section so you don't disturb the conjunctiva superiorly, if possible. If a glaucoma patient is there and is on medication, personally, I don't like to do premium IOLs for them in case they need a filtration surgery in future. But that is my take on it. I'm not really sure what the recommendations are right now. Also, since peripheral vision is an issue, so I think we should take that into consideration before going for multifocals.
We would not do a multifocal in a glaucoma patient. Contrast sensitivity is also a question, and we would not like to compromise on that. So glaucoma patients are a no-go for me.
Yeah. Actually, sir, we were talking about a lot of unhappy patients, unhappy because of the refractive part. Can you please advise us on what to do? Because mostly I've seen many people with very good vision being unhappy because of foreign body sensation and watering.
Let me ask a question to everybody.
They keep coming back. It's watering.
No, let me ask a question to everyone. Which is the largest complaint a patient comes post-op with you?
Dry eye related,
Itching, any cataract operated patient, which is the largest complaint they all come with?
Sir, दुखता है.
Watering and irritation. Watering and irritation.
सर कुछ लगता है अंदर में है.
आपका लेंस खटक रहा है.
अंदर में है.
चुभता है.
Irritation and watering.
Correct. So irritation and watering. These are the two main complaints they come with, madam. So you are absolutely right. All of us have it. My patient will come to you, your patient will come to me. So in fact, I tell during my LASIK talks that dryness after LASIK is over exaggerated. Actually, it's more after cataract surgery. 14 out of 10 patients complain of khatakna and redness and burning.
Sir, you just face the complaints. We face patients going to bigger city from small city and changing their Sustain Ultra to some other tier substitute and coming back. So it's, I think,
Madam, we all face
those
this
are,
problem.
yeah, those
We
are
all-
patients which are.
Dr. Rashi, you are in capital town. Don't say that you are in a small town.
I promise them, I'll tell you how to deal with it. Like I promise them with multifocal that ring दिखना चाहिए. आप लाइट के सामने देखो ring दिखता है कि नहीं. अगर ring नहीं दिखता है, I'm not joking. अगर रिंग नहीं दिखता है तो मैंने गलत लेंस डाला है. अगर रिंग दिखता है तो मैंने सही लेंस डाला है. ओ यस दिखता है. वेरी गुड. करेक्ट लेंस है. दैट मीन्स फोकस में. दूसरा, आई प्रॉमिस देम ऑन डे 1 एग्जैक्टली कि ये मैं भविष्यवाणी कर रहा हूं, ये होने वाला है आपको. आंख खटकेगी, लाल रहेगी, पानी आएगा, चुभन होगी. ये भगवान ने दिया हुआ है. ये इसी प्रकार से हीलिंग. अगर ये नहीं होता है तो हीलिंग अच्छा नहीं हो रहा है.
Good. And of course,
Sir, gajab ka
tell
tika,
them
sir.
and at least diagnose MGD in all those cases. There are at least 35-40% who have significant MGD. Tell them beforehand कि इसको अब ड्राई आई है, आपको बाद में ट्रीट करेंगे जब वो, या फिर पहले थोड़े दिन जहाँ बहुत ज्यादा है पहले ट्रीट करेंगे, नहीं तो बाद में उसके लिए फर्मेंटेशन मसाज देंगे. ओरल मेडिकेशन अभी शुरू कर रहे हैं आपको, उनको एजिथ्रोमाइसिन या फिर
I
उनको
think Dr. Bharti request you for the third topic.
ओके, बट ये तो बहुत ही मजेदार रहा कि भाई अगर
Yes,
रिंग
sir.
दिखती है,
Fantastic.
मतलब तुमको सही लेंस लगाया, एकदम सही चल रहा है.
और अगर इरिटेशन नहीं
और
हुआ तो
इरिटेशन है तो
ठीक नहीं हुए.
तुम्हारा हीलिंग हो रहा है. और अगर इरिटेशन नहीं है मतलब तुम्हारा हीलिंग ही नहीं हो रहा है. ये तो बेस्ट रहा सर, बेस्ट रहा.
जब फर्स्ट डे पेशेंट कहता है जी पहली आंख में तो कुछ नहीं हुआ था इरिटेशन, ये दूसरी आंख में हो रहा है, तो पहली आंख में कुछ गड़बड़ जरूर हुई होगी, तभी इरिटेशन नहीं हुआ. इरिटेशन तो होना चाहिए था.
So over to the third topic, very important, the surgical complication by your colleague. Tricks that teach you the way to talk. So sir, should we start from Grover sir or Himanshu sir?
I will just finish this because I'm just wanting to go to the other room. Sorry, sir. Would you like to talk first? I would be more than happy.
My privilege to hear you first.
No, sir. My privilege to be sharing the stage with you. The first thing. I know I'm the president right now, Bombay Ophthalmic. I literally shout at most people and I'm doing this for everybody to be together so that nobody cribs about the other person. When I get a patient who is cribbing about somebody else, believe me, this patient will go and crib about you to somebody else. Be very clear about that. Be very clear. Never, ever criticize your colleague. You are cutting short your own thing. वो जाके हंसेगा, आपके ऊपर ही हंसेगा. It's very easy to say, हाँ सब अच्छा किया है, लेकिन this is the problem with people. And I tell you, the best are the doctors in US. Some of our patients with that big worm goes and shows, despite seeing very well, they go and show an ophthalmologist there in US. But a US guy in a teaching institute calls his residents and tells them, look at the quality of surgery done in India. Sir, you don't have to come to US. Please, you have done a wonderful job there in your country. This is what has to be told to your patient. So what I tell patients when there is a complication, I was not there. I'm sure, first of all, no doctor likes complication. We don't like any problems in our patients. That's why we are doctors. Each case is different. And I also get my own set of complications. What happened to you? I was not present during surgery. I have not seen your eye before surgery. So let me not talk about it. You have problem today. I will help you from the day I entered in your life. I have no answer to talk about past, and I have no right to talk about what I have not seen. So let's not talk about it. I cut short the postmortem. That's it.
Couldn't agree more. So first thing is, if the patient comes agitated after a difficult time that he's had after surgery, I will first spend a little extra time with him. I'll sit down with him cool him down, talk to him after he sits down comfortably, spend a little extra time listening to his concerns, spend maybe a little extra time examining him also, and then in a very matter of fact way, tell him that these are the problems at present and that this is what needs to be done. Now, if he brings up the question of that any post-mortem or whether this was done properly or not, or whether there has been a complication or not, what Dr. Himanshu said is precisely true. All that you have to say is, I have no idea what your condition of the eye was before surgery, whether it was predisposed to some problem or not, what were the circumstances during the surgery that may or may not have led to a difficulty or a problem that you have now. So we have no idea about what might have happened. And there is certainly no way in which we are going to criticize a colleague. I've never once done it in my life. So, and not with your implied gestures or your voice tone or with your words, of course. So that is important, that you don't have to convey it in any oblique way or anything, because it carries a poor impression of you as a person to the patient. He will, of course, be very happy if you corroborate that, oh, it wasn't great or it wasn't very good at that place or something. He'll be very happy to hear that, but he would not rate you as a great person too. He would be much happier to know that you are a balanced person, that you don't tend to blame others for things. Eventually, he will realize that you are the better person for him to look after the things. That is what I would like to say.
Dr. Vibhuti Bhushan Jamshedpur, I'd like to ask you one question. You know, in cataract surgery, one of the major complications, which can damage the eyes, probably one of the complications is damaging the cornea. Number one. Number two, after PCR, damaging retina. And number three is having glaucoma. So what is your take? Suppose somebody comes with the, messed up cornea. So you do not know what kind of a case it was, what happened. So how will you talk to the patient about the surgeon who has operated? He's a high volume surgeon. That's why I'm asking him.
Sir, once again, we have to take care of the words that we utter in front of the patients. What Professor Grover said, that we don't know what was the situation, how hard the cataract was, how the patient was behaving on the operation table, and how much difficulty the operating surgeon was experiencing at the time of surgery. So we don't actually know the situation, what was there at that time. And exactly what we can do, what we are seeing at that point of time, we can try to improve it from there. We can try to help that patient from that situation. So that is the first thing, that is the goal. And keeping that in mind, we need to say whatever we say to the patient, this thing has to be at the back of our mind, that these are the conditions that we are not aware of, what was the situation at that time. And whatever the situation may be, we can explain them that sometimes what happens is in advanced surgeries, we need to apply energy to break the lens inside. Sometimes the lenses are very hard and we need to apply more energy that the eye cannot take actually, and it takes a longer time to heal. So these are the things that we can actually, we need to work as we need to speak as a shock absorber basically, because the patient is already in difficulty. He has had a surgery. The condition is not very good. So we have to be really very careful and sympathetic also towards the patient, giving him hope that it is going to improve. We will definitely do something. And we have some very good cornea experts, fortunately, in our state. So we can always go and take their help. If it is beyond our realm, if we feel that we are not the right person to manage such cases, then we can definitely take the help of the super specialists, the cornea experts, and refer the patients to them.
Again, a sandwich
will add-
technique works well.
Yes, sir.
Let's say if the cornea is damaged, you tell them, see, the good news is that your lens is well in position. It has been done well. It's absolutely fine. And again, with a positive, you can tell them that there is corneal fluid collection, which may or may not settle down in this much time. If it doesn't settle down, it can be taken care of this way by grafting or whatever. But tell them that there is a way in which this can be handled. So, and again, with the good news. So sandwich technique somehow tends to work well for most things. Give them the good part of the news, then the bad part, and end with a hopeful note.
Sir, I would like to add one point. Like sometimes the patient come with the corneal decomposition in the one eye, and when we examine the other eye, we find gattata, we find undiagnosed EBMD, then we can tell the patients that if we operate in the other eye, we will have the same corneal decompensation, which is already there in your first eye, but you were not informed. So the other eye also is having gattata or the EBMD, undiagnosed, corneal dystrophy, undiagnosed. And sometimes patients come with both eye gattata, then we pre-operative communication is also important. Then we write, sir, that this patient you have this and you might develop corneal decompensation later on. You may need disectomy later on.
Well, if you tell them that this thing you were not informed, then there is some problem. Because then the patient might have some negative vibes about the previous surgeon. So, I think there's some.
Actually, we can say
Yeah, so
that this is a cornea facility.
I think what I generally do is, because he has had some problem in that eye, so we might be more careful while doing the other eye surgery. We might do some more investigations to find out some hidden reasons why he developed that kind of a problem. And we'll try to avoid that.
Dr. Jakhanwal, what is your take?
Yeah, that is one thing I like to say. First, tell the patient that this is a treatable.
Sir, screen share करिए.
चेहरा नहीं दिख रहा, ठीक है.
Yes, I like to say the first tell, because patient wants whether he is not seeing, whether he will be able to see or not in future also. So you can tell that it is a treatable. So it can be treated, and you direct the patient to the referral center where it can be taken care. If there is a corneal edema and corneal decompensation, that is what I have also seen one of my cases in which we have done very good surgery, everything, and the person was VIP. First day, the cornea was okay. After few days, he developed a corneal edema. And then at that time, we were not having any endothelial counts and everything. So we have sent him to outside. And when the endothelial count was done in another eye, it was seen that is so very low. However, that eye has recovered later on. So first, give the hope that this is a disease which can be treated, and send the patient correctly to the place where it can be treated and support. So that is what the sir was telling, the sandwich technique will work over here.
Okay, can I share something important, Dr. Bharti?
Yes, sir.
A very important point in the whole thing is it could be the retina also, ERM.
Yes, sir.
Despite you thinking that in patient ka kharcha ho jayega, don't hesitate in doing a corneal endothelial cell count. Don't hesitate in doing the retina examination OCT. Don't hesitate in doing a biometry. Don't hesitate in doing any test for the sake of the patient, because the same patient will come and blame you if you have not done it. So I insist on every patient of before surgery, whether they pay or not, a corneal endothelial cell count, a retinal OCT, and an IOL master or whatever that you want, optical biometry, must be done without question, because it all boils down to you trying to save patients' money. That's where they come and really start bothering you. So please don't worry about their money because you don't want to take the flat.
Sir, mostly there is a package for the premium IOL investigation. There is a package for the premium IOL investigation which includes OCT. If it can be done, if the patient's cataract is not very dense. So in our place, it is a package for premium IOL investigation and OCT is included in that. So
Yes.
what about others? Vibhuti?
Sir
Dr.
is telling not for premium, for any cataract.
Every
We should
cataract.
do the endothelial count.
Endothelial count is must for every case. Even in Ayushman patients, we do specular. For premium IOL, we make a package and that package includes OCT also.
So one
So the
point
question,
I would,
the whole question is, if the patient has, messed up cornea and the patient has come to you, how do you deal with the patient?
Cornea surgeon is there.
I'll tell you. When I meet such patients, whether it's a cornea or a glaucoma or a PCR and RD or a drop nucleus, I said, fantastic surgery. बहुत बढ़िया surgery हुआ. दिख क्यों नहीं रहा है? वो असल में कुछ दवा डाला गया है, उससे थोड़ा सा reaction है. It will be all right. कुछ करना पड़ेगा. The moment you say the operation is good, the patient is happy. उसका आधा तो ऐसे ही निकल गया चिंता. And the person who has done the surgery, वो बाद में जब पता चलेगा तो he'll be also happy. And I'm not going to lose anything when I say that the surgeon was good and did this good surgery. Ultimately, whatever surgery you have to do later on, DMAC, DSEC, whatever it is, or PK, whatever it is, you have to go ahead and do it to correct that. Because the reaction from drug, you don't have a say on that. If it has to happen, it will happen. The same thing with the PCR. Beautiful surgery, very nice, fantastic. लेकिन आपका ये problem था, इसलिए कभी-कभी ऐसा होता है. Don't worry, it will be taken care of. I never ever talk bad about my colleagues, no matter how messed up it is. So the best thing is to say, beautiful surgery. And then whatever problem we have the answer for that. We can treat it. So that way, I think a lot of things are taken care of. It is what I do. I feel that I have served my patient. I feel that I have served my junior colleagues. I feel that I have made business for myself.
So any suggestion, tips from Dr. Bharti Sharma? She is a cornea person.
Yeah, ma'am. So I would like to add that whenever you see a corneal decompensation after surgery, we don't immediately recommend a DMAC or DSEC. We always wait for 4 to 8 weeks, hoping that the cornea will clear. We tell the patients that sometimes your cell counts are less age-related and it will take some time. We hope it clears in another 1 month's time. This is the first thing. And if we see the other eye on slit lamp, you can always see gutted changes in the other eye. You can always recommend the surgery under viscoat. Please don't forget. I have done a lot of patients with Fuchs dystrophy with the cell count very less and successfully done phaco, taking care how to do the phaco with viscoat cover. So this is another important point we all should remember. Use viscoat or coat liberally to cover the endothelial cells and do the surgery. 90% of the time we get away with it if the patient doesn't have any corneal edema. But document, as madam said, we have to document the patient has gutted changes. This and all will go in our favor. That's it.
The documentation is very important. We have to document in the EMR also, in the patient sheet also, because बाद में कहते हैं आपने तो मुझे बताया नहीं था. आपने तो बताया नहीं था. So many cases we get when the endothelial count is less, Gatata is there, EBMD is there. So we have to explain before the surgery that this might happen. So I have seen all my cornea surgeons writing that you may need DSEC or DMEC in future, and the result of DMEC I have seen is so good. The patient becomes 6/6 after beautiful DMEC surgeries. So I have seen the results of Dr. Nidhi and all. So there is no problem after the DSEC and DMEC has come. And Dr. Himanshu Mehta sir, are you there? Dr. Grover sir has left. He had to go.
I'm there. I'm driving.
Both of them are here.
Okay, sir. So now just vote of thanks from doctors, from our secretary, Dr. Mitra. Mitra ji.
Yes, Doctor, it was a very indeed a discussion, and it's a very wonderful discussion, and we have so many things has come out from this discussion. So it will definitely help in our practice. All of us are doing either in private practice or we are working in the private hospitals. Actually, there are so many questions still remain unanswered, like what about the underpricing due to the competition? What will the pricing about the presence of complicated cases? So that will again deal with some other time or some other days. I thank our guest speakers, Dr. Himanshu Mehta sir, and our Professor Dr. A.K. Grover sir, for giving us opportunity to hear you today evening. From their busy schedule, they have taken out time for us. I also thank all the panelists, all the discussants, all the senior members of JHOS, and also I thanks the Enter Pharmaceuticals for giving us the platform for this today's evening webinar. Thank you very much. Thanks once again.
And one more thing I would like to add, that the Himanshu sir is from Bombay. There is a Ganesh Chaturthi big celebration in Bombay, and he has to visit so many places. At that time, he took some time out, and now he is driving for visiting people during this festival time in Mumbai. And Ashok Grover sir also went for some Ganesh Chaturthi festival. Both the sirs were very busy with the puja socialization. Still, they took time out and interacted with us and gave so many tips.
Good.
Thank you, sir. Sir is driving. He's. I can see him. Himanshu sir. I can see Himanshu sir. Thank you, Himanshu sir.
Thank you.
Seatbelt, sir. Seatbelt.
सर का रिंग दिख रहा है कि नहीं? वाज द सुपर हिट?
सब सुपर हिट। रिंग दिख रहा है कि नहीं दिख रहा है मतलब गड़बड़ है, लेंस अच्छा नहीं है, लेंस काम नहीं कर रहा है। और दूसरा कि अगर आंख में लाली पानी है मींस तुम्हारा आंख बढ़िया से हील कर रहा है, और अगर लाली पानी नहीं है तो बढ़िया से हील नहीं कर रहा है।
So, Dr. Saab, if you remember general surgery, what was a healthy wound taught to us?
Yes.
Remember something which there is ooze, there is plasma, it is red. So I tell them this, let me make it one more point. I tell them, why do you eat good? Why should you eat good food? Because you want to have blood.
You want to have?
You want to have good blood. Your
Blood.
good healing. So you don't have to call 911 whenever there is an injury, surgical or otherwise. Automatically the red blood cells reach there, and when the healing is over after 6 weeks, they will disappear. That means your body is functioning properly. Am I scientific or am I not scientific?
Fantastic.
Fantastic.
Thank you. Thank you very much.
Thank you, sir. Thank you, sir.
Just fantastic moments.
Yes.
So I think on the next webinar, we should be talking about, the pricing of the surgical items, the surgeries.
Yeah, that I have taken out from the bag of the baskets, from the basket actually.
Yeah.
There should be there are two topics which always come in my mind: underpricing for competition. This is one of the great topic now, and pricing about the presence of complicated. Like in the complicated cases, what will be the pricing from the normal standard pricing, or it will go up or go down according to the situation or presence of the So
we should not be talking only about pricing. We should also talk about what should be the correct pricing, even in Ayushman Bharat or CGHS or ECHS or TPS and all. We should be what should be the correct pricing? Because मैं तो बोल के थक गया AIS के MC में कि भाई there should be somebody representing us and stating the correct amount of money that we should be reimbursed for our surgeries. But it never happened. So probably with our webinar, something might come up and then we might, submit something.
Sir, if you say something and all that, it will never happen.
You are correct. Good.
It can happen is going legal. Only way is to do that is that, and there is no other way out. All these requests and
Sir,
will years.
Sir, what about company people forcing us to buy the new instrument and then they don't stop supply of the older one every 10 years, sir?
But all that we have to take it as a part of our expense. We have no choice. That is company policy. The whole purpose is this is the normal norm in the world. We have to digest it and charge accordingly, taking care of that. And again, I'm repeating, I started my talk with that we are no value for ourselves. We are strangers in the mirror.
Yeah, we should not underprice ourselves.
Yeah.
We are underpricing ourselves big time, sir. मेरा starting का talk इसी के ऊपर था, sir. मैंने यही बता रहा था.
Yes.
Okay, we are, and take my word, this word is very important to me, stranger in the mirror. We have no value for ourselves.
Sir, your YouTube channel name is Mirror?
Yes.
Mirror wisdom. So I have some good, smart dignitaries where I act as a mirror to reflect whatever their depth of knowledge is. And which is why to me, this statement is very important. Stranger in the mirror. Most people are strangers in the mirror. 95% have low self-esteem and 5% like Mr. Trump have very high self-esteem. Nobody really can look at themselves naked in the mirror. They have tremendously low self-esteem. And we all ophthalmologists are second to that. I'll not bore you with a lot of philosophy.
Sir,
but this is
your YouTube has a surgical videos or your instrumental videos?
No. These are some of the smartest people in the world who talk on various subjects, from cryptocurrency, religion to whatever in life that you want.
Okay, very nice.
So we have had KK, we have had crypto, you name it. You had the police commissioner of Bombay, you had the 2611 hero. So anything but ophthalmology.
Good.
Very nice.
Nice topic today. I thank Dr. Bharti Kashyap, our CSC, to bring out these topics today. And behind the scene, there are a few persons, like one of the person is Prem Lata. She has done a tremendous job connecting all of us. Thank you very much once again.
Please introduce, she's the secretary. Or secretary to CSC. Your
Okay,
favorite.
bye. Okay.
Thank you. Thank you. Good night, everybody.
Bye.
Good night.